Good afternoon, everyone. My name is Sita, and I'm a Health Information Coordinator at the Bureau of Infectious Diseases at the Department of Public Health here in Massachusetts. And the reason I'm speaking to this is there, as you know, five major components of meaningful use that public health agencies are expected to participate in. And I actually have responsibility from the NDPH side for three of those. I routinely put this slide in just so that anyone who doesn't know about meaningful use has the background. I'm sure that this audience does, but I'm sure also that Ryan went through the background to meaningful use and why we're all engaged in this. I want to focus on this from, as Ryan said, the programmatic perspective and the responsibilities of the public health agency. And as you all know, there are these five components that as a public health agency we are required to participate in. I'm proud to say that Massachusetts stepped up and said that we were facilitating data submission for all five, which not all states have done. And as you also probably know, there are immunizations. We have an immunization registry to which eligible providers and hospitals submit data. The syndromic surveillance, which we collect from emergency departments of hospitals only. There are electronic lab reports which come from eligible hospitals, cancer from eligible providers only at this time, and specialized registry also from eligible providers only. And I'll go into a little more detail around that in a minute. We do also have three other nodes that are not part of the meaningful use construct at the moment. I personally find these initiatives very exciting, and I think they are actually very good examples of how data can be transmitted through the HIway from user to provider and back again. And I will touch on them if I have time. We all know what the aspiration of the HIway is. It's about facilitation of the electronic reporting of health information. It's about minimizing administrative challenges. It's about helping people attest to meaningful use. It's about assuring fast, secure, consistent data communication. And I'd like to step into the actual five nodes that we're using for meaningful use, beginning with the immunization system. There's a before and an after picture here. And as you can see, in fact, we were collecting immunization data for the registry before the HIway. And we're continuing to collect it, except now it's going through the Health Information Exchange. So the pathway is very similar, as you can see, but using the HIway presumably offers all of the benefits that Ryan was describing earlier on. If you're a hospital and you're submitting data, it absolutely makes sense to be able to send all your data through a single pipe to the state as opposed to using multiple methods of communication. Just to give you an indication of the scale, there are 7 organizations actively submitting data right now, 10 are testing, and the program tells me that there's anything up to 100 organizations that are still to connect, of which perhaps 65% are large enough in terms of the population they serve to be eligible for meaningful use funding. The node on the HIway is actually in production. The challenges as we speak are that vendors, and you'll see I have a challenges next steps slide for every single one of the nodes, and the challenges are similar across the board. It's about vendors, data providers having different EHRs and trying to make them consistently meet the requirements of the HIway. So there has been, as Ryan will attest, a lot of work being done on trying to standardize these interfaces. The next steps for immunization are, that they will continue working with vendors. They supply solutions, they facilitate solutions as much as they can. And the other thing is talk to data providers, which is something all the programs do, as well as the HIway, to offer guidance on how to attest for meaningful use. Because certainly my experience is that the documentation has not been clear, and we do get a lot of questions. Syndromic surveillance, we never did collect before meaningful use required it. It's new to us. We had, we've decided, the state has decided that we will limit syndromic surveillance data collection to hospital emergency departments only. It will all come through the HIway, and it goes to BioSense, which is a data repository that's sponsored by the CDC and sits in the Amazon cloud. We have not got any data providers in production as yet, so it's very difficult for me to make a judgment on how successful this is or how effective the data collection is. But I would say that if I'd spoken to you a week from today, we'd probably have had 3 or 4 hospitals in production, because it's moving very fast with syndromic surveillance, and I think we're really on the verge of beginning to get good data in. Again, the benefit of the HIway is that it offers a single method. And in terms of scale, we have potentially 70 eligible hospital emergency departments. 52 have registered their intent to supply syndromic data, and 36 are testing. Now, we do have non-hospital providers calling all the time and wanting to submit syndromic data, but really they are excluded from this because the state has declared that it's from emergency departments only. And my understanding is that BioSense only holds data from hospital emergency departments, and because we're using BioSense, that's what we're limited to. The challenges have been very similar in terms of trying to finalize linkages between the different systems. We have made it possible for those hospitals that are waiting to submit data to still attest to meaningful use stage 2, and I'll come to that a little later. Electronic lab reports, again, we've been collecting, in Massachusetts, we've been collecting ELR for a very long time. And 71 of our 73 eligible hospitals already successfully submit electronic lab reports to us. So the before picture, they send ELR to our health information portal, and it's working very well. We've actually had our health information portal certified for meaningful use as well. So we go the extra mile and offer coverage to all hospitals for meaningful use stage 2. The HIway offers an effective alternative way of submitting data. Certainly there's one hospital using the HIway to submit ELR, and at the moment we are offering hospitals the option of using either methodology, because we think it's nice that they have the choice. But as Ryan says, there is a certain amount of discussion about how we can consolidate this. And certainly if you're a hospital, again, and sending multiple data sets to multiple places, it makes sense to consolidate those. So using the HIway potentially does rationalize maintenance and transmission of data. Just in terms of the HIway node for electronic lab reporting is in production, and Beth Israel Deaconess Hospital uses it successfully. We've had not too many challenges with ELR precisely because we've been doing it for such a long time. The cancer registry is really interesting because cancer has been collecting registry data reports from hospitals for a very long time. I spoke to the cancer program, and if you look at this box on the front, in 2011 they had approximately 60,000 reports. But the 6,000 non-hospital reports are the ones that they find extremely difficult to get a handle on. And this is where something like the HIway comes into its own, because there have been methods and ways for hospitals, big organizations, to transmit data in the past. But it's been extremely difficult to collect data from non-hospital providers, primary care providers, other clinics that send through cancer reporting. And if you look at the before picture, they send the information in all sorts of different formats. There's a lot of manual intervention and pre-processing, and as a statistician and an informatician, I can tell you that every time someone touches the data, that's scope for error. So it really has been an unsatisfactory solution in terms of getting data from non-hospital providers, and use of the HIway actually can fix that. And I believe the Cancer Registry is very excited about this because everything gets simplified. So you have your eligible providers who get onboarded onto the HIway. The data comes through the HIway pipe and to the appropriate place in the Cancer Registry, and there's minimal intervention. So in this instance, certainly the HIway offers a solution that wasn't there before. I know, I think I've just addressed this slide. I know that there's one very large provider who is working with the HIway team right now to onboard. I believe the HIway node is actually live and functioning, and so they're just waiting for the provider to make whatever changes are necessary to start sending data. The specialized registry is the one MDPH component for meaningful use that at the moment does not use the HIway at all. We have declared our infectious diseases surveillance system, MAIDEN, to be a specialized registry, and we collect electronic medical records for certain diseases, for hepatitis, for TB, and for sexually transmitted diseases into our surveillance system. And I know we get, I told you already that we already get electronic lab reports, but the EMR actually offers us pregnancy data, treatment data, ICD-9 and 10 codes. So it enhances the data that we've got, and it's really very helpful in terms of triaging for programs to work out which patients they need to focus on first. We have actually 2 organizations currently submitting EHR data. It's technically a little complicated in that you have to have algorithms that can go into your EMR system and identify which cases you want to extract data from, and then format them into the appropriate format and send them through to us. But if anyone wants to discuss this with me, I'll have contact details at the end of this presentation. So the other thing I did want to address is that a lot of folks have been very concerned about the fact that they're not actually able to send production data to us, and how do they attest to meaningful use. But if you look at the meaningful use requirements for stage 2, there are multiple ways in which you can reasonably attest. So you could have achieved ongoing submission, or you could be actively engaged in testing and validation. That is good for attestation too. Or if the public health agency has a long queue of folk waiting to onboard, you just need a letter from the agency saying that you're in the queue. So all that meaningful use tool requires is that level of engagement. So I just briefly want to touch on these other initiatives, which I personally think are very exciting. They're not part of the meaningful use family yet, but I think they really are the essence of what meaningful use of health information is about. The first one is IEATS, which is about collecting information about clients in opioid treatment services. So again, if you see the before picture, it's really very complicated. Data sent through email, there's manual uploading, there's SQL processing, and if you look at the after picture, it's really straightforward for providers to send data very securely through the HIway. And these are non-traditional data providers, if you like, and it absolutely makes something that was very difficult before feasible now. I know this is actively happening. I think the node is live in production. There are 7 abuse treatment organizations representing 45 services that are eligible to do this. There are 3 vendors who are engaged with the HIway, and there have been challenges, I think, for vendors to connect with the HIway, but it's on its way. The same challenges. It's about getting different systems in sync with each other. And the next steps are to onboard the vendors onto the HIway. The Childhood-Led Poisoning Prevention Program, again, I think this is a brilliant illustration, and I can say that because I didn't make it, of all the multiple formats and ways in which lead data comes into their database and how much more simplified it can potentially be. I think this is exactly what health information exchanges should be about. There are approximately 60 providers, just to give you a sense of scale, and I think Ryan will have more of an update than I do on this, but the node for childhood-led data is in progress right now. There's no provider sending data as yet, but it's work is being done on this as we speak. And the final node that I wanted to talk about was about e-referrals, and that's exchanging data from healthcare provider organizations to community-based organizations. So this totally bypasses the state. So it's really about organizations out in the community sending data to each other. And again, I think this is a very clever notion, and I'm very excited to see how it works. And if you want an example of the types of health provider organizations we're talking about, it's things like the YMCA or the Tobacco Quit Line working together with community-based organizations. And these are people who currently use paper or, mail or faxes. And if they're going to be able to send data securely to each other back and forth, I think that's going to be amazing. So in terms of health information technology and the health information exchange, I hope that I've made it clear that this is, in a way, the future and where the future lies. I think if you've seen the slides and from your own experience, you'll know that there have been challenges. I would stress that these challenges apply to all states and all the HIEs. A lot of it is to do with the different legacy systems that are already in place, and with the trust issues that Ryan touched on earlier. But I absolutely do think that when they get bedded in and they start working, they will enhance, improve our ability to do what we do better at a reduced cost. So it's really about, for us, it's not just about meeting meaningful use 2 requirements, it's about increasing the utility of the data we collect to improve public health. We do have a very brief page on the web, and I'll put the address in here. What it does do is it gives you the phone numbers and the email addresses of people you can contact for each of the 5 meaningful use programs. And I didn't give you too much detail about the technicalities here, but if you call in, we'll be able to provide you with what you need.